Those are nice. Somebody saw me, I would say next to when I was
Yeah,
in a giant block. I'm not going home.
Yeah, I pulled
You know
some
what, for
random-
certain
some
ones
random-
that you can tell,
What?
if you take 2 lefts and a right,
Wait, what?
take 2 lefts and a right,
For what? Trying to get someone up?
like to see
Yeah.
if they're actually following.
Who's
you.
basically going straight? Yeah.
Yeah.
But that way, it won't like tip them off. Because if you go in a giant square, well, obviously that's what you're trying to do.
Yeah.
But if you go 2 lefts and a right,
I'm gonna do
I don't know, man. I don't even pay attention around me, I guess. So.
Oh, no, I was always away. I got like pepper spray with me, you know, I have a little taste.
I think everyone's out to get me, so like,
Yeah.
I walk somewhere. I'm probably gonna get kidnapped around my husband, because that's when I'm like, he's got me, I'm cool. But when I'm by myself, I'm like hyper aware.
Yeah. I need to get some pepper spray because I am planning on starting to walk like at night at Overholser. So I need to have something. So that's the only time I have time. So, you know,
Yeah, I can't walk at night because I can't see
yeah.
where I'm walking.
I will just say it is not a safe place for me to walk at night around my apartment.
I've lived in apartments like that.
Luckily, this apartment has only had 1 bad incident, and it was like 2 years ago. And it was a random drive-by shooting.
Oh, man.
Where is this at? It's on Northwest Expressway.
Apartments were called Walnut Village, but they called it Sin City in the bad side of town. And somebody got stabbed on the porch.
Oh my god.
I know, and that was like the 90s.
Yeah. My mom told me the story. They just got done on a rodeo and they were walking into this motel. And there was this scuffle that I pulled up on.
But we can talk in the morning.
Oh my gosh. My freaking Amazon guy, it's just stacked up like all the way to my ceiling on my porch. All these boxes. I just saw it on my thing.
Yeah.
Oh my god, there's like 20 boxes out there.
I don't know what you're saying. A college
Well-
professor makes you rich.
It does not, believe me.
I figured that was not the case.
Yeah. No, but I do, I like Halloween, and so we've ordered a lot of like stuff for decorations, yeah.
Amazon is so bad.
Yeah, it's too easy to spend a lot
Are
of
your
money.
dogs gonna have costumes?
They don't like,
spaghetti and meatball
so,
already?
so Spaghetti will wear a little costume and Ripley will wear a costume, but Meatball hates like clothes and stuff on. Like he had a full on panic attack last time we tried to put a sweater on him. So I don't think we'll be putting anything on him, but maybe a little hat or something like on his collar because he's okay with that. But
I don't know, we like for you to put pajamas on her, but she'll fight you to do. It's like she's excited to know. That's what my dog does. Every time we just adopted him like 3 weeks ago, and every time we walk in, he's 70-pound people. He just puts her.
We had an English mastiff that did that too. He just stuck it in there. Yeah, that was it. There's no biting.
Someone dumped a doodle dog out where we live, and she found the neighbor's great pyrenees. Oh, but then we were crossing 11 puppies. Oh my god, yeah. They told us she was gonna have 6. Oh, I'm sorry. We didn't do it. I was not the tech. I know, it's okay. You can't always tell. Not that I actually know. I only have 1 male and 1 female left. Fine. So they're visual pyrenees. They are very cute, and like the
chillest dogs you've ever seen in your life. So chill. Yes. Okay. No more check off. I'm done for the rest of the program. That gets so stressful. The anxiety. Yeah. Right. So. Right. So final further class is on my master.
Oh, yeah.
But not every. It is. It feels that way.
I don't know how to get this taken away.
We have a whole lab Sunday tomorrow. That's my government.
Oh, okay.
We don't cut everything off. For tomorrow. That might be what we're doing. I know it's no blood products ever. Like we can't even handle blood products.
Sorry, I see green and I see
All right, we'll go ahead and get started. All right, for chapter 10. All right, which term refers to all of the chemical reactions that occur in the cell? All right, the term for all of them altogether is going to be metabolism. Remember, catabolism is going to be breaking things apart, and anabolism is building things, which I think is the next question, if I'm being honest. Yeah, anabolism. All right, so this anabolism does involve building molecules, but it also, if you're building, you're going to need to put energy into that building process. So we're going to be using the energy. All right, enzymes are an example of what macromolecule? All right, so they are in fact going to be proteins. Most of you guys got this one. So enzymes are proteins. They are amino acids. Nice little chain folded up just right into specific shapes. All right, where does the substrate bind? All right, excellent. So you guys got that one. That's going to be the active site. All right, what are causes of denatured protein? So how can you denature protein, basically? All right, so this is going to be pH, heat, and chemicals. We mostly talked about pH and heat, barely touched on the chemicals. We'll talk about some of those chemicals whenever we get into chapter 11 and unit 3. All right, what best describes non-competitive inhibition? All right. Non-competitive inhibition means that the inhibitor is not going to be competing for the active site. So the active site is where our substrate binds, right? So non-competitive, these are going to be guys that attach to what we call the allosteric site of an enzyme, which is also known as the regulator site or regulatory site. Same thing. All right, the 5-carbon sugar that we find in ATP. There's a 5-carbon sugar in there. Which one is it? Alrighty, so our 5-carbon sugar that's found in ATP is ribose. So that's our sugar. Remember, ATP is a nucleotide, basically, but it is 3 phosphates instead of just 1. So phosphate's just phosphate. That's real that it is. Adenine is a nitrogenous base. Glucose is a sugar, but if we'll recall when we learned about aerobic respiration, glucose is a 6-carbon sugar, not 5. So ribose is our answer. All right, aerobic respiration requires what? So pretty much a gimme. All right, most of us are getting this one. Let's see. Why that doesn't go away, but it does. All right, so when we're talking about aero up here, you can think of aero as being like air. O, think of that O as being oxygen. Anytime that we're talking about aerobic respiration, there's 3 kinds of respiration, only 3. And they're going to be aerobic, anaerobic, and there's going to be fermentation. All right, there's only 3. And if you can remember that fermentation, if you remember any of the weird, it's the weird one, right? It's the outlier, so to speak. So fermentation only has glycolysis, and that's it. And it stops there. Whereas whenever we're talking about aero, this is only glycolysis. Aero has gly, anaero has glycolysis. This also has Krebs, and this has Krebs. And this has an electron transport chain. And this has an electron transport chain. So what's the difference here? The difference is this. Those proton motive force, those protons that are coming in, that we can't let it equal out on both sides. And those electrons, as they're moving through the electron transport chain, they can't be built up. We have to get rid of them. The way we get rid of those electrons and H pluses in the arrow is going to be thanks to O2 being our final electron acceptor. One of the most missed questions on the Unit 2 exam. What's the final electron acceptor? They still have electrons, they still have H pluses. How do they get rid of them if you're anaerobic? Well, not oxygen. And that's all you really need to know about it, but it will be things like nitrate and sulfate and carbonate, but not oxygen. And that's why it's called anaerobic, okay? So the big difference here, in case you haven't been paying attention to what I'm saying, they're the exact same up until their electron acceptor. That's it. The electron acceptor is the thing that differs between aero and anaero. Like I said, this concept, knowing the electron acceptor at the end of these guys is one of the most missed questions. All right, let me click on this and then we'll go. That's not gonna let me. Here's this. I can't just like click with you. All right, the gas produced by yeast in alcoholic fermentation. So if we have alcoholic fermentation, so you already know we're going to be glycolysis because I just said. But what gas is produced? Right, so the gas that is produced by alcoholic fermentation is going to be carbon dioxide. Do we also make ethanol Yes, we do make ethanol. That is in fact the alcohol that makes it alcoholic fermentation, but that is not a gas, that is a liquid, right? So that's why that's not the right answer. So carbon dioxide is our answer for this one. And that's what makes your beer or whatever bubbly. I'm sure there's a way to like erase that all at once. I just don't know what it is. Not smart. All right, during photosynthesis, plants use what gas to produce glucose as their food? So I'll remind you guys, plants have to make their glucose. They are not ever gonna get it from their environment. And they use a gas to build it. Actually, 30 seconds. All right, so this is gonna be carbon dioxide. Carbon dioxide is our inorganic source of carbon in photosynthesis. It's what we're gonna be, basically linking together in order to make our glucose molecules. Good job, guys. All right, so we're gonna go straight into, you can go away. Yep, chapter 13. Let's do it. So chapter 13 is going to talk about disease in humans, basically how it's presented and how it comes to exist in your body. But first we want to understand what's going on with your biome. That's your microbiome. So all of the bacteria that normally live on or in your body. So us plus those bacteria, we call that the holobiont. You guys remember those holoenzymes being the whole functional enzyme. Well, we are holobionts, the whole functional biont, or human with our microbiota. Some of the terms associated with this: colonization, causing disease. So infection is whenever you have microorganisms that are going to basically take up house and start growing. Usually multiplying and existing very happily there. So that's true infection. Having one or two in your body might not count, but if they're multiplying and creating a new home there, then that's going to be the infection. So disease, this is going to be any deviation from health. Yes, it's a pathologic state. Does disease have to come associated with infection? No, right? So you can have diabetes and heart disease, cancer, and all of these things that have nothing to do with infection. But of course, we're going to be talking about infectious diseases for the most part in this class. So you can have infection that can happen without any symptoms. Usually it'll eventually get to symptoms though. But if you have an infection that isn't leading to any symptoms or signs, then that's not really a disease, is it? So you can kind of have one or the other without it. But usually you'll have something there. All right, like a fever or something. Okay, so our normal biota, what you guys have to know about this, it can be bacteria, fungi, protozoa, or virus. So there's 4 things it can be: bacteria, fungi, protozoa, and virus. There's one group that's not, included in this category. I'm not considering archaea because of course archaea isn't, but the group that's really missing is the helminths. So our parasitic worms, they are not part of our biome. But these other guys could potentially be. Let's talk about our relationship between our bodies and then microbes that may live on us or may be invading us. So when we are colonized, that means that there are other creatures living on us. So we have our resident microbes. These are the green guys. These are your normal flora. The Staphylococcus epidermidis on your skin, and all sorts of stuff on your body. We'll go over all of them, but anyways, we have some potential pathogens. So these might potentially cause disease if they cause infection first. Again, potential. I didn't mean to draw it through it, but you get it. Okay, and then we have the transient microbes. So these are just passing through. These are pass-through microbes. Okay, so things that can happen, we could have potential pathogens or just general transient bacteria just coming into our body and then going. They're gone. What does that mean? It means you ate something that had salmonella on it, but it was just a couple maybe of bacterial cells that wasn't enough for them to establish infection. So now they're gone because your body cleared them out. That's all that means, okay? There's plenty of bacteria that we come into encounter with. There are plenty of bacteria that we encounter every day, whether that is, you know, if you had your food sitting out on your table and not on a plate, even your plates, like are your plates sterile? Probably not, right? Or somebody gives you a piece of food that you ate, or you're breathing in, like when you're walking by somebody that could have just been coughing but isn't sick, there's still bacteria involved in that, right? It's just not necessarily a pathogen. So these are all transient microbes. The microbes that we just see and they don't cause any infection. So that's transient. Just they're not necessarily potential pathogens once you've got a real big problem with your immune system. All right. However, potential pathogens and sometimes even your own resident microbes can cause infection. So if you are somebody who has E. coli in your colon right now, which you probably do, almost all of us do, as part of your biome, it does stuff for you as just, you know, a microbe that lives in your gut. That if it's doing that and it's being there and it's doing fine just there, that's fine. That's not an infection in and of its own, right? However, if that E. coli gets from the colon into the urinary tract through the urethra, either usually due to poor hygiene, maybe not, wiping. That's why I say women should wipe from the front to the back. It's not to transmit any bacteria into the urethra. Or during sexual activity, that's why they recommend after sex, you're supposed to urinate and wash up as you see fit to help prevent these sorts of things from happening. Of course, it's not perfect. Wouldn't it be nice? It would have saved me a lot of trouble last week. But anyways, these things, so that E. coli doesn't belong in your urinary tract. It belongs in your colon just fine, but it gets into your urinary tract and starts growing there. Now that's an infection. So infection is either going to be pathogens that are pathogens setting up house in your body anywhere, or your resident biome growing either where it shouldn't be or out of control where it already is. So an example of that one would be, hey, if you take your antibiotics for your urinary tract infection and then clear out all of your normal bacteria in you know, the genital area, and then you will have overgrowth of yeast because they aren't killed by antibiotics, right? Antibiotics only treat bacteria. So you can have a yeast infection. It's very common to have yeast infections after treating UTIs with antibiotics. So the yeast is normal. It should be there in small numbers, but if we have overgrowth of it, that causes a problem. That's an infection and not just the normal colonization that we would expect, right? There's a lot of stuff that could fall into that category, like C. diff. C. diff is pretty common part of your colon biome, but you take antibiotics, you kill off everything in your colon, and the C. diff survives because it has endospores, and then it grows out of control and creates an actual disease because of that, right? The thing that I like to compare this to is I say that it's like we all have a big old stadium with a whole bunch of seats in it, and all of those stadium seats are taken up by the good guys. When you take an antibiotic and then C. diff is left sitting there all by itself, it's thinking, all right, cool, I'm gonna spread out a little bit. And so it does, and that's how it creates that problem. When normally, when you aren't taking the antibiotic, the other guys that are sitting there, it can't spread out, right? All the seats are taken. So that's how come you need to maintain that normal microbiome that's going on in your body. And we kind of already know about disease and death. I'm not gonna go over it. They're doing a project to try to identify all the microbes that could potentially be in your body. One such term that you should be familiar with is microbial antagonism. This is a pretty good one. It's pretty much what I just explained to you guys. Having microbes in your body naturally helps prevent you from getting pathogens established and infection established. Taking up the stadium seats, using up the nutrients that are around in the area, all of these things can prevent pathogens and overgrowth of other organisms. So that's called microbial antagonism. They are antagonists. You guys don't know protagonist versus antagonist. The antagonist is like the bad guy in the story. Well, in this case, they're fighting off people for you. But There's a fight going on. All right, I'm not going to go over the weakened defenses. You guys mostly know that. Anything that could stress out your body in any way can weaken your immune system and make you more susceptible to infection. Terms that you should probably know: endogenous infections versus exogenous. Endogenous is caused by biota that are already in the body. So then your normal biome, like we said with the E. coli, like we said with the C. diff. And then here's another example, Streptococcus pneumoniae. You can have that normally in your body. And if it's a normal strain that is a pretty tame strain, it could potentially cause pneumococcal pneumonia. Even in AIDS patients, they would need to have that reduced immune system in order to get from their own biome, which would already be tame to them. Now, I'll say this for Streptococcus pneumonia, we're going to talk about it more in other chapters, but it is a bad deal, man. It is one of these bacteria that causes so many different kinds of infections. It's just nuts. But Streptococcus pneumoniae is the #1 cause of pneumonia in the world, and is the #1 cause of meningitis in the world. Well, bacterial meningitis, I'd say, but probably viruses are more common, but you get what I'm saying. So it's bad. If you get it from other people, you're more likely to have that than your own biome. All right, where do we get our biome though? Like, how did we fill up our stadium seats from the get-go when we're growing up in our mom's belly? We think that the first exposure to bacteria is going to be in the womb. This is still under study, but there's pretty significant evidence suggesting that we are actually getting exposed to bacteria in the womb. It's not as sterile as we thought it was. The bigger exposure, though, is going to be coming on during birth. So this is going to be vaginal versus C-section births. If you're born from a C-section, you're basically getting pulled into a very disinfected area. They want to be as sterile as possible, right? That's the whole idea. So you're not getting any encounter with a lot of the bacteria that most organisms. Something happened on my watch and it's happy about it. I don't know what, but making colors. So whatever. So if you're going through the birth canal, there's a lot more bacteria, right? I think we can agree with this. In the actual vaginal cavity, we're talking here about normal bacteria that would be there, of course, and yeast that would be there, of course. But there's also the potential, if you have an STI or things like gonorrhea or herpes and things like that, could be deadly to the baby. And even just strep, having strep bacteria in the vaginal canal that wouldn't be harmful to you at all could be deadly to your baby. So they'll usually test for that pretty close to birth and give you antibiotics to treat it to hopefully prevent that from happening. But other bacteria should be basically colonizing your baby and giving it its first real big, hit of the biome. Next, we have the breast milk. Breast milk, of course, has its own microbiome, and we're introducing that into the baby whenever they drink the breast milk. It has bacteria that will be able to break down sugars in the milk that the baby cannot break down on its own. So if you have sterilized sterilized formula for your baby, then it's not going to get the microbiome introduced into its gut, and it could potentially have issues digesting milk and other related products that bacteria would typically do for them. They can pick it up later on in life, but sometimes that can just predispose you to other GI issues. So you want to try to pick up baby formula that has probiotics in it to help foster that. Then, of course, being exposed to other people and things in your environment, like pets and just being hanging out outside on the ground or whatever it is, can also help get those stadium seats filled with bacteria. Now, of course, whenever you have those stadium seats filled at first, do they stay that way for the rest of your life? No, you're going to get exposed to all sorts of weird stuff. And as you go through growing up, you'll see new things. As you go through puberty, it's going to have a massive change in your body, pH, and things like this, that cause a shift in your biome. Whenever you have, sexual contact with somebody, every time that there's sexual contact could potentially be introducing new biome into your environment. And then as you age and you have a decreasing immune system, that could change things as well. There's other things too, pretty much anything. All right, how the infection progresses, we of course know what a pathogen is. It's a disease-causing microbe. We have two kinds. The first one is the true pathogen. This is going to cause disease even in healthy people. The second one is the opportunistic pathogen. So this is the guy that's going to take the opportunity when it is presented. And so usually we're going to have our defenses compromised, or we are moving to a different part of the body, someplace not natural to them. So this would be defenses compromised if you've taken an antibiotic and you've eliminated all of the stadium seat people that were in there. Now that was part of your defense. Now it's compromised. So that's when C. diff can overgrow, for example. When they're in a different part of the body, like the E. coli that got into the urinary tract, the urethra is just a pretty obvious one, but that would be going into a different part of the body. So those are opportunistic pathogens. Opportunistic pathogens are also going to be things like fungal infections in folks who have lowered immune response and things like that. All right, virulence. Virulence is defined as the degree of pathogenicity. Pathogenicity essentially means ability to cause disease. And the degree of that is the virulence. So how much of an ability does it have to cause disease? How strong is its ability to cause disease? So this is going to be indicated usually by the microbe's ability to establish itself in a host and cause damage within the host. So here we're really talking about ability to cause disease. We're talking about disease here, not the infection part. Yes, the infection is important. You have to have that for the disease to happen, but the disease, that aspect, the change in what is, deviation from your health, that is what we're kind of measuring here. So we need establishing ourselves in the host and causing damage. Anything that aids in either of those things, establishing ourselves, so establishing the infection, or that helps with causing damage in the host, those are called virulence factors. That could be anything that helps with that, including, like we had mentioned previously, things like flagella. If it helps you get to where you're going, it's a virulence factor. All right, the infectious dose is just a term relating to the number of microbes that you need for an infection. An example would be a lot of viruses have an infectious dose of 1. You only need 1 virus in order to cause the infection, potentially. Tuberculosis has an infectious dose of 10. So you need 10 actual bacterial cells on average to cause infection. And then like things like salmonella, it's like 50 to 60, I think, somewhere in the upper end of it, but it requires quite a few. So if you only have you're eating your chicken and it only has a couple of those salmonella bacteria on it, in general, it's probably going to end up being transient because you need a lot more than that to establish that infection. In order for them to survive and stick where they're supposed to stick and get where they're going and really flourish, they need a lot to start with. So
is that different for different people, like the infectious dose?
it could be, but they typically are going to list it according to each microbe. So on average, yeah. All right, here are our steps involved in causing disease. We need to get in, so that entry. I'm not going to go over these. These should be obvious. Breaking in the skin and the GI and stuff like this. Okay. Attaching. So this would include fimbriae. These are little appendages. Remember these? We talked about the fimbriae. We talked about the pili. We talked about the flagella. And the fimbriae were the ones for attachment. Capsules, sticky coating, okay, other surface proteins on microbes, and the viral spikes that interact with those exact little targets on the cells, right? Right, we have to get into our cells. Great, you've attached where you're trying to go, but how do you survive? You have to avoid phagocytosis or avoid death in the phagocyte. So either avoid getting eaten up, like we talked about with the capsules, right? Or you've got to live inside or not be killed by the actual phagocyte. Or there has to be some sort of absence of specific immunity, meaning that they are, it's hard for the body to create antibodies against them or something like that. So just evading the immune response. All right, next we have causing damage. This is where we actually see disease being presented. So this is going to be direct damage. We'll either have enzymes or toxins. Anything that's going to be causing direct harm typically is going to be a toxin. So if it's affecting the cell, our cells themselves, it's typically a toxin. It's toxic to the cells. We can have enzymes that don't affect our cells that can help with disease. Like we already mentioned one of them the other day, which was collagenase. So breaking down the collagen between the cells to get deeper into the tissues, that's going to cause damage. That's causing damage to our structures. But if we have any toxin that we're actually exuding from the cell, outside of the cell, and it's attacking our host cells, those are going to be toxins. So we call those exotoxins. And I'm sure you guys remember another type of toxin. There's only exotoxins and then one other, endotoxin. If you guys don't remember endotoxin is always just endotoxin. It's never a trick name. It's not got other things going on involved in it or anything like that. Endotoxin is lipopolysaccharide. And where do we find that? The outer membrane of the gram-negative bacteria. Always. I told you guys it would be coming back over and over again, and I wasn't kidding. Okay, so here it is again. So we have two types of toxins. Exo, the ones that they're going to push outside of the cell and then it causes damage, or endo, the ones that are part of the gram-negative cells. All right, and then you of course have the enzymes. All right, and then we have getting out of the host. You can control the host chromosome as well. Remember how we can insert our DNA into your cells? For HIV, you can insert its DNA. That can control your genetic information, as well as there can be other proteins that they can produce to control that stuff too. All right, exiting. I'm not going to go over that one because that one's pretty obvious as well. All right, let's go. Be aware of the fact that there can be placental infection. The placenta can work as a barrier, but in some cases, when we have diseases that can cross that barrier can actually be a downside because now we can't get immunity to the baby to help it out. So that could be a huge problem if we have bacteria that are able to cross that barrier when our immune system really can't for the baby, not effectively anyways. So that can lead to serious issues with babies, like we're talking about listeria, which is why they have you want to heat up your lunch meat and things like that. It's listeriosis. You're supposed to cook your lunch meat when you're pregnant, because if you get an infection with listeria, it's not a big deal for most adults. You might feel a little sick and maybe have some GI problems, but for babies, it can be deadly. So you don't want to play with that. Same thing with toxoplasmosis. And you're handling kitty litter, you get the protozoa from toxoplasma, and then it gets into you, and you maybe feel like maybe flu-like symptoms at the worst. I mean, that's unlikely. Most people don't have any symptoms at all. But if you have a baby growing inside you and it's in a certain part of terms like the late term pregnancies, that you're likely to have stillbirth as a result of that infection. So you don't want to mess around with it. So not always a good thing to have that barrier there. Can't help the baby out. Okay, so we already talked about attaching to the host a little bit, so I'm not going to go into detail. But remember, you can always form a biofilm and communicate with the bacteria nearby by they can sense your waste products as well as other molecules that you might be making, and so they can say, "Hey, he's doing good over there," and respond to that, or "He's doing bad over there," and respond to that. Here was our examples of the fimbriae, the capsules, and then our viral spikes, helping us adhere to our host. All right, now we have to survive our host defenses. We got in, we have stuck on, now we have to survive. So phagocytes are our white blood cells that engulf and destroy pathogens, right? You would think of macrophages or neutrophils, something like that. Some organisms have anti-phagocytic factors that can help them survive this. These would be considered virulence factors. They would have to be, right? Because it helps them to survive these situations. So this could include even killing the phagocyte. Some of these guys can evade the phagocytic process, either by making it difficult for the phagocyte to engulf them. If they're difficult, that would be like your capsules, right? What we're familiar with. Or they can become adapted to survive inside of the phagocyte. This would be an example of this would be tuberculosis. There are special macrophages that live inside of the lung called alveolar macrophages. So the alveoli in the lung, those little tiny sacs, and the macrophages that live there. And tuberculosis bacteria will be engulfed and eaten up by the alveolar macrophages, but that's where they want to be. That's where they thrive. So, is really what happens. Trying to get rid of these guys, and we're actually just helping them out. So here's just some examples of the associated virulence factors associated with causing disease in a host. It could be a whole slew of stuff. structures on the pathogen, enzymes that they make, all sorts of stuff. So let's talk about some. The proteins that are secreted could be enzymes that, like, again, break down stuff around in their environment, like our collagen or hyaluronidase or whatever it is. And then it could be proteins that are going to cause damage to the cells themselves and how the cells function, cell death, and those are going to be toxins. Okay. You can also affect the genome. I know I'm not going to test you over that, surprise. All right, so exoenzymes secreted. So they're giving it onto the outside. This would include things like mucinase, breaking down literally mucus. Keratinase, breaking down the keratin, like on the surface of your cells. And then hyaluronidase. This is an enzyme that breaks down hyaluronic acid, which works like collagen in your extracellular matrix. So it can penetrate tissues deeper. All right, so here's our toxins. Again, these are a chemical product of microbes of some kind that is poisonous to other organisms. So it's going to cause cell death of some kind. Exotoxins are the ones that are secreted. Exo being outside, we're pushing outside. And remember, endo is only going to be LPS. It's not secreted. And it's only going to be associated with gram negative. It really is just the same old endotoxin. This is a plate that is showing hemolysis. We've seen this before, but this is gamma hemolysis, so there's not any hemolysis here. Alpha, we have green, so partial hemolysis, and then we have beta with complete hemolysis. These guys here, that's because we had enzymes that were breaking down those red blood cells. Some organisms are going to cause damage in the host by causing an excessive host response. So excessive amount of inflammation in the body, more than it would like normally have against something. So if you're fighting off a bad guy, you want some inflammation, you want some attack going on, but if it's too much, now you're causing damage to the host tissues. That could be just something that happens in the body and it's not really a boon to the microbe. It might not like that, but other ones kind of flourish from it. You cause the host to cause damage to their own body, and now you've damaged tissues. Now we can get in deeper and you're more vulnerable. Just depends on the microbe. So an example that we have here is for COVID. If you had long COVID, which is people who continue to have COVID-like symptoms or weirder symptoms that go on way after. So like you don't have the virus anymore, but you're still having the symptoms. That's usually because of an excessive host response, an overstimulated immune response to COVID when you had it. Let's talk about some patterns of infection. We have localized, these are pretty straightforward. Like if you had a boil, right? Systemic, all over. Focal means that you had an infection, like let's say in your throat or nasal cavity or something, and then that spread to another area of your body, like might cause endocarditis. You guys have ever heard about how you can have gum disease and it can cause infection in your heart, right? That is the same thing. That's gonna be a focal infection if that happened. So it's not all over your body, but it did spread outside of the original area. Then we have mixed infections, kind of speak for themselves. It just means there's more than one microbe involved in it. And then we have primary versus secondary. Let's say you had a urinary tract infection, you took your antibiotics, and now you've got a secondary vaginal infection, like a yeast infection or something. As a result, that's a secondary infection. Oh yeah, it goes over them. I forgot. I always forget that. Literally do it the whole freaking 2 days, and I would never remember that it does that. Okay, acute versus chronic, easy. All right, acute comes on rapidly and it's short. Usually has stronger symptoms associated with it. Chronic infections are going to progress slowly and persist over a long period of time, and they usually have more muted symptoms and signs. So what are signs and symptoms? They are two very different things. A sign is anything that is measurable or observable. Whereas a symptom is, let's say, subjective. So this is usually going to be reported things. What do I mean by these things? What is a measurable sign? A sign would include something like a fever. You can measure that. You could include vomiting. You can see that that actually happens, right? You could have swollen lymph nodes. I'm just putting swollen nodes. You get it? You can palpate those. I don't know, bleeding, red eyes, even blood work, like blood work numbers. Anything that you get from that. If somebody's jaundiced and they're yellow, that's a sign. Okay, anything you can see and verify. What happens whenever your patient tells you that they are experiencing pain? If you work in a hospital, especially if you're in the ER, you will see a lot of people coming by that want their pain treated when they don't have pain. Not really. They just want the drug. Very common. But also because you're a hospital, if somebody's coming in and complaining of pain, you have to take them at their word and treat them. So you'll be treating people, if you work in an ER, you will absolutely be treating people who have drug problems that all they wanted is their drugs. They want you to give it to them. And that's all you can do is give them their drugs. And once they feel better, kick them out. Give them a rehab pamphlet or something on their way out. And that's the most you can do. But pain is reported. Even if somebody's sitting there yelling, ah, do you know that it's really like actually pain? You can't tell. I was in the ER when I had pancreatitis. I was waiting in the waiting area for 3 hours. And there was this lady there who was also waiting for quite a long time. And she just kept sitting in her like wheelchair, just like, ah. But then sometimes she'd be like on her phone, like on her watch or whatever and doing stuff. And I'm like, I don't know about you. Like, I don't know. Because she was just saying like she's been in pain. She won't go away and she's been in pain. Every time that the nurses would come out, right? And then she was back to playing on her phone or whatever. So I'm just like, I don't know, man. But pain is so hard to prove. So you have to take it at your patient's word. Pain, this would include even a headache, yes. So the high blood pressure could be a sign, but the pain still, you don't know. So you would have to, yes. So could you say, I mean, here's the thing too, right? If you're dealing with like an animal that they have signs that they are actually, sick or whatever, and they're in pain, or like you clip their toenail and they yelp out, are they faking it? No, right? They're not. Humans are the liars. So that's where this becomes an issue more than anything. Even nausea, you can't actually prove that and measure it. So this would be a symptom. Just stuff like that. And fatigue. Yeah, yes, unfortunately, yes. And so even though folks like, I mean, every time that I've gone to an ER, it's been like legitimately I've been in pain and I don't go because I want attention or medicine or anything like that. And most of us are probably like that. And in fact, if any of us probably in here were to go to an ER and we were in pain, we would probably be like flabbergasted that they would assume that it wasn't actually as bad as we're telling them. But I guarantee you, if you haven't been a patient in an ER, they're going to treat you like you are not actually in pain and you're making it up 99% of the time. So. Mm-hmm. Yeah, I hate to say it, but in the ER, they are just really not likely to believe anything that you tell them. They're just not. So it should not be like that. It shouldn't. Yes, yes, yeah, it will. It will. Don't start off that way at the very least. Right, so yeah. Don't. Give yourself a few years to get to it. Yeah. So be aware that there are plenty of symptoms and plenty of signs, and they are different things. Measurable, palpable, if you can actually interact with it. I think of it as like if you had a stop sign, that's something that you can like actually see and interact with. But if you had a stop symptom, that's not a thing. So how do you, yeah. So that's how I remember the difference between the two and which one's which. Then this other word down here is syndrome. It's not really related to these two. It's kind of its own thing. I don't know why it's on the same slide, but it is. Syndrome is a disease that is defined by its signs and symptoms. One of the ones that we have been talking about pretty regularly in this class has been meningitis. So talking about that stiff neck, having a headache, sensitivity to light, having a fever, maybe nausea, things like that, maybe even a rash. These signs and symptoms are associated with meningitis. But is meningitis caused by one thing? No, you have to figure out what is causing the meningitis. Is it a bacteria? There's a lot of bacteria. Which one? Is it fungus? Which fungus? Is it a virus? Which virus? But they're all meningitis. So it's the same disease. Another good example would be the cold. If you have a common cold, the common cold is caused by, there are like 200 or more viruses that are associated. I know it's at least 200 viruses that are associated with common cold. So you go to the doctor and they're like, well, you're negative for the flu and you don't really have a fever, but to have all the other symptoms is probably a cold, right? It's just a virus, and they'll just send you home. Well, which one though of the 200 possibles? They usually don't test because you're going to probably be fine. And but that's really a syndrome because we didn't know which virus it was that was causing that, and it could be a number of things. So anything that is like pneumonia can be caused by a lot of things. But if I were to talk to you guys about the flu is caused by influenza, and we know that. COVID's caused by the COVID virus, right? SARS-CoV-2 or whatever it is. All of those things. So there's differences there. So syndrome is like the disease. Yes.
So are there colds that are like worse than other colds?
Yeah, of course. Yeah. So there's definitely colds that are worse than other colds, depending on what virus you have. They even throw RSV typically into the cold category, especially if you're an adult. But if we're talking about even with meningitis, there's worse and less worse forms of meningitis. But there's a lot of those pocket signs and symptoms that we can throw in and say this is meningitis though. And they all cause true inflammation of the meninges. It's just what did it. So.
I just have a quick question.
Yeah.
Just curious about RSV. Is that becoming more common, or is there like a recent vaccine that was available? I'm just noticing a lot more ads for.
So there's a recent vaccine.
Okay.
Yeah. So that's a newer thing that they're pushing that's become that's out of clinical trials now, and you can actually get it like through your insurance and stuff for certain people in certain situations. You can get RSV vaccines. As far as I wouldn't have known that except that since my husband works for OBI, they got a lot of questions about it because it's not on their like question list or whatever, and it's not listed on like things like what vaccine have you had, and it's not on there, so they have to keep calling like the medical people and get it approved. But yes. Anyways, so things that are going to be signs, these are anything that you could measure. You could actually listen to your chest sounds and see that somebody has an abscess or something like that. You can measure the amount of antibodies in somebody's serum. Things that are symptoms, pain of any kind, malaise, just feeling like shit basically, fatigue, any itching that you don't see true like hives associated with it, nausea, cramps in the abdomen, it's really hard with those ones. Sore throat, you can't see those. Okay, moving on. Signs of inflammation. The three that we are concerned with here is going to be edema. So this is fluid in the tissue. You'll see swelling typically of the area. That's because the cells that are going to fight the good fight for you have to come in with fluid, basically. Then we have granulomas and abscesses. These form because your body's trying to wall off infection with cells. And then we have lymphadenitis. Itis, anytime that you hear that, whether it's meningitis, lymphadenitis, vaginitis, I don't care what it is. Itis always means inflammation every time. But anyways, lymphadenitis is swollen lymph nodes. Because you're fighting an infection, that's where your white cells are going to come from. All right. No, we already kind of talked about these. I'm not going to go over some of these details, but some words that I would be aware of is septicemia versus bacteremia. Bacteremia is small numbers of bacteria. Any bacteria in your bloodstream is not cool. Like you're not supposed to, it's supposed to be sterile. Your blood is supposed to be sterile. So if you have any bacteria in there, that's bacteremia. It's a bad sign, right? If they're growing and flourishing and establishing infection in your bloodstream, that's septicemia. So this is when they're flourishing. I don't know, flourishing. So know the difference between those two for sure. If you have an infection that is unnoticed, it could be because asymptomatic. Subclinical is just, it's an infection that when you go to the doctor, they can't see the signs or symptoms of, or they're just inapparent for whatever other reason. So typically you are going to see a sign or symptom associated with most infections though. And then once you have your infection, now it has to get out of your body to go somewhere else through any of the portals. We think a lot of coughing and sneezing, but it could be, in the urine, in the feces, in the blood, or via an insect bite. when you have an infection and you have, it's been there for a while, let's say, and it goes away, you have no symptoms at all, but the bacteria or the virus is still there in some form, whether it put itself in your DNA or it's literally just hiding out in like deep, dark recesses of your body. That's latency.
Is that mostly viral things?
So we think a lot about the viral things because we talk about like, chicken pox and stuff like that. But there are quite a few other ones. And in fact, all of these down here are non-viral. So syphilis is bacteria, typhoid fever, that's salmonella bacteria, tuberculosis is bacteria, malaria is a protozoa. And all of these can enter latent stages by just hiding out in certain parts of your body. Malaria can hide out in your liver cells and then, come back out later on. It's uncommon, but it does happen. Tuberculosis is actually pretty common to have latent TB. So you get exposed to it and usually don't have any symptoms right at first, maybe a little bit, and then it goes completely latent where you have no symptoms at all. And then it's like whenever it comes back out is whenever you get the coughing of blood and all that. Yes.
There are factors to like someone that is having kidney issues, like different morbidity.
It depends. Like, so it probably has a lot to do with the immune system of that person and the bacteria that they're being exposed to. It could be any number of things. There's a lot. It could be the immune system. It could be the bacteria. It could be the tissue or the anatomy of the kidney. There's a lot of stuff. Or, some people, if they're not hydrating enough, it just depends. It's a good question. All right, so sequelae. These are long-term or permanent damage caused by the infection. So examples they give here, if you have meningitis, you can go deaf. Strep throat, you can get rheumatic heart disease. So that's because your body fights off the strep bacteria. And when it does that, the antibodies it makes against the bacteria happen to match your body tissue. So it will attack your heart as well. That way, your body is attacking your own heart. Then we have Lyme disease that can cause arthritis. Again, it's a similar sort of concept. And then polio. Polio led to paralysis, pretty famously for that, right? We have FDR in his, wheelchair because of that permanent, and he didn't have polio in that, right? He had already cleared it. He just was paralyzed forever because of it. All right, the courses of an infection mimic pretty closely. Oh, good, I'm done. I know I'm cranking, guys, but I want to get through both of the chapters, and I just want to get the important stuff out. The incubation period. This is the time from whenever you get the actual thing introduced into your body up to when you start having symptoms. Okay, so you were introduced to it. You got exposed to somebody with COVID. You're like, oh crap, I had to work with so-and-so and he just got tested positive for COVID. So probably in the next 5 to 14 days, you could pop positive for COVID, right? Are you gonna have symptoms within that time period? Maybe not. It might take 14 days for symptoms to pop up. But could you be growing it in that time? Yes. So that's what the incubation period is. You're growing up that thing, probably not having any symptoms or signs. That's what that is. So then the next one is the prodrome or the prodromal period or stage. This is when you have your first symptoms. This is whenever, if you were exposed to, John Smith at work and he had COVID, and then 5 days later, you start having this sort of tickle back in the back of your sinuses and a little bit of a sore throat. And you're like, oh, geez, it's coming. That's the prodrome. Okay, that's the signs that you'll get that you are starting to get sick. The prodromal period. The acute phase is whenever you are at your absolute worst, and it keeps getting worse and worse, and you just are at your worst. You're like on the couch with 104 fever, and you're just sore all over, and you've got the chills, and it just couldn't get worse. That's the acute phase. And then we have the convalescent stage. Usually, this is when the patient is clearing out the infection, either themselves or from medication. So your symptoms will start to decline, and you're killing off. These things actually line up pretty well with the bacterial growth curve that we talked about before. But anyways, there it is. And know what these things are. There will be a question about that for sure.
Does it ever not progress all the way to the and the other, do you ever get the prodromal and then your body starts to fight it off and then it doesn't get that bad?
Yeah, I mean, it depends on the illness and if you've been exposed to it before.
Right.
And of course, we have some where you could have the incubation phase, but your body's fighting it off then, and you might not have ever known that you were exposed. So yeah, both of those could happen. Okay, so reservoirs are where these things normally exist in the wild, if you will. Source is where you got sick from. So if yeah, let's see, I'm trying to think of a good example. If I were, let's say they're having an outbreak of COVID in France, and I fly out to France and I get sick and I come out here and then I get you guys sick, I would be your source, right? But am I the reservoir? No, it's not being maintained in me. Okay, cool. This could be an individual, like if I were to do that and come and cough on you guys, or it could be an object. And what I mean by object is it could be the source. Like if I was at this computer and people just kept getting sick coming up to this computer, and like what we're going to learn about John Snow. Yes, we're going to learn about John Snow in a little bit from epidemiology, that he stopped a cholera outbreak at a water pump. People were all going to that water pump. That was the source, right? And so that's an object. That's not a person. So you can think of it that way. But yeah, you get sick from using this keyboard, and I cough all over with my COVID, and then Dr. Tim comes and uses it, and Dr. Singh comes and uses it, and they're getting all sick from my COVID from using the keyboard. That's the source, probably. All right, carriers are people who are sheltering pathogens without knowing it, or without being fully aware of it, at least. We have people who are asymptomatic. They just have COVID. About a third of people who have COVID are asymptomatic, a third. So they're not showing any symptoms, but they're completely contagious. They don't know that though. So asymptomatic carriers, that's not really their fault. Incubating carriers, you were exposed to somebody with COVID. You're not showing symptoms yet, but you can still be contagious before you start having symptoms. That's incubating. Convalescent carriers, you had your COVID, but you feel pretty much better. You're ready to go to work. You're well enough to go to work, but you're still spreading out the virus. That's convalescent. Chronic carriers, people who are basically having a long illness associated with the thing, but they're still interacting with others and spreading it, and it's just become part of their life to have this part of their body. That can be the case with tuberculosis, like when it's latent. So you don't know that you're harboring it. Passive carriers, this could be if you're at a hospital and the doctors aren't changing gloves, or the nurses aren't washing their hands, or whatever it is. All right, so reservoirs can be living, so they can be maintained within actually actively alive beings. It doesn't have to be always the water pump or the pen or whatever other thing. So things can be alive that can transmit these things, including actively ill people. This can be transmitted via indirect or direct transmission from these live people. Indirect would be this keyboard or this pen, okay? So if I lick this all over and I leave it here, and Dr. Rhodes comes up here and he starts using it, and he gets sick from me, then he got it from my pen. The direct transmission, I cough on you and you get sick. It's sort of self-explanatory, right? You can also have people who are recovering or, infected with latent diseases that can get other people sick. And then we have things like arthropods, which is an important one. This is a term to be aware of. An arthropod is like a biting insect, okay? So that includes fleas, mosquitoes, biting flies, and ticks. If they drink the blood, they can transmit the disease. Sometimes an arthropod is infected actively, but sometimes it's just carrying it, okay? All right, that brings us to that concept of biological versus mechanical vectors. Biological, these guys are infected. These are vectors that are transmitting you to the disease, like a tick. Some ticks are actually actively infected with the disease that they're spreading onto you. If we're talking about malaria in mosquitoes, the mosquitoes are actively infected, like the protozoa are growing in the guts of the mosquitoes. So they're actually infected. Another biological vector would be birds with the flu. I'm sure you guys know that one. All right, then we have mechanical vectors. Mechanical vectors, they're still living, okay? They're just not sick with the thing. They're just carrying it. So examples are biological vectors. These guys are gonna get you sick by biting you or coughing at you or being near you or whatever it is. They are infected, like our bat with rabies. Bats, by the way, bats commonly have rabies, so just be careful. I'm just gonna say. Mechanical vectors, these are not infected. I think bats are cute, by the way. I just don't want them in my house. Oh, right, yeah. So because they have like bird flu or whatever, so they can poop and get you sick or whatever. Don't touch their poop or whatever. I don't know. Okay, yeah, that's true. Mechanical vectors, these guys aren't infected. So like it shows cockroaches and flies. I feel like it's pretty self-explanatory, but they're running across poop and they come across your food. Now you've got poop food. They weren't infected. They're just carrying it. All right, zoonoses are diseases that are associated with animals. They're normally found in animals. Obvious one is rabies, of course. So zoonosis, kept in animals, but you can sometimes get it. Hantavirus. Hantavirus is one with rats and mice. Then West Nile virus. West Nile virus is maintained within the bird population. If you didn't know that, it's spread by mosquitoes. Anthrax is maintained within bovines typically. Plague, we have that in the rats. I'm not gonna go over all of them, but you get the idea. So here's a list if you want to see more, okay? Non-living reservoirs are anything like in the environment that isn't alive that you can get sick from the thing, okay? Like in the water or something. You can have diseases that are communicable. That means they can be spread. Then we have contagious. That means they are highly communicable. So those are not the same thing, right? And then non-communicable diseases. So you can get sick and have an infection, but it's typically not going to be spread from person to person. I get sick and have an infection. Let's say I'm running. What happened to me in real life, and I still have a scar from it. I was like 7 or something. I remember it because I was listening to the Monkees on like my cassette player, and so listening. And I was rollerblading or something and down the street, and I fell. And my mom had told me, don't go rollerblading without, you know, me or your dad out there to watch you. But I didn't listen, and I went and I fell and I scraped my knee. So I came inside and I tried to wash it off myself, but you know, I'm a kid and I'm terrible apparently at these things. So it got infected. And but is that contagious? No, it's not gonna be contagious, right? So that's what the difference is gonna be with these. I saw the scar from it though. It wasn't even that bad. All right, horizontal transmission. If you fall. Horizontal transmission is like between two people or a whole group of people. So between anybody, but vertical, which is the other side of it, is between like the mother to the child. Okay, so vertical is like mother to child. Horizontal is person to person, anybody else. Like direct or indirect. Here we have indirect transmission, kind of being spelled out for us. We have a vehicle, anything that can transmit infectious agents. Then we have a fomite. This is an inanimate object that will transmit pathogens that is not a continuous source of infection. A vehicle can potentially be like when we have the water pump, that could be a source, but it's a fomite, it's just like a transiently associated thing, like a pen that Dr. Rhodes comes and uses and gets COVID from me. All right. Oral fecal route. Not really one we want to think about, but this is not direct, right? Oral fecal, somebody didn't wash their hands. They bring you your food out from on the border and you eat it and you get sick. Typhoid Mary type of situation. Okay, you can also get it from water, soil, and air. Cool. When we talk about the air, we're typically talking about droplet nuclei and aerosols. So droplet nuclei are like dried microscopic pellets from the mouth and nose, whereas aerosols are suspensions of finer dust and other particles. Okay, they can hang out in the air for hours, and some bacteria can survive in the air for hours like that. And then Robert Koch was the guy that we talked about previously, but he's the guy that came up with the steps, the postulates, to determine what the cause of a disease was. So he used steps to figure out what the cause of anthrax was, for example. Cool. I'm glad we are done with that. Now we got chapter 14. Whew. We can do it. We can do it.
Is there gonna be like a lot of 13 on the test?
I don't remember. I wish I had the answer for that. Because it's a lot of info, but it's like a lot of terms more than anything. So it's not so bad. That's why I feel like not terrible ranking through it. Because most people can just make flashcards of that. And it's not like a whole lot of application really. But Anyways, same kind of deal with these, okay? The epidemiology stuff is a lot of terms. So epidemiology is the study of the who, what, where, when, and why of disease of any kind. We're gonna talk about Florence Nightingale and John Snow. Florence Nightingale, during the Crimean War in the 1800s, I guess, she noticed that the soldiers were dying a lot, even though they were like stabbed or something. They go into the hospital and then die of dysentery that wasn't associated with stab wounds or whatever. She realized that the doctors and stuff, they weren't washing their hands or practicing any hygiene procedures really at all. So she introduced that stuff and saved people's lives. So she went from 32 out of 100 people dying to only 2 out of 100, just with her implementation. So that's Florence Nightingale. Then we have John Snow. He was a guy in the 1800s London who realized people were getting cholera. So he mapped out where these people would live in Soho in London. And then he found out that there's all around just one water pump and they were all using the same water pump. So he took the handle off of it and guess what? The cholera stopped. So he's considered one of the fathers of epidemiology. This is just his map. And at the time it was so serious, they even had it like little cartoons about death running the water pump and stuff. Cholera is a terrible disease, by the way. It causes rice water stools. It's like, it literally, if you boiled water and rice and took just the water out, that white color is what you would be pooping out, that white liquid. And that's because all your poop is gone, because all you're doing is pushing out, that has a toxin in it that causes you to push out all of your liquid, your basically hydration and your electrolytes. So you become severely dehydrated. When you get cholera, they put you on what they call a cholera bed. It's a bed with a hole in it and a bucket under it. And that's what they'll do for you. So yeah, it's one of those things that typically for most people, it's going to be self-limiting to a degree. You're either going to like be okay and survive it, or you're going to die because you dehydrated so badly. So it's pretty high mortality. I want to say it's like 20 to 30% mortality rate. It could be maybe even 50 if you're in like a third world country with this situation, but there's usually they don't give antibiotics for it because it's just like no point. You're either going to die from it fast enough or you're going to get over it.
Is it like parvo involved?
Kind of, but I would say it's, I don't want to say worse, but so I guess it's similar. Yeah. But I mean, yeah, you're definitely not like, this is not poop anymore. It's like, we're way past this. All right. So you don't want cholera. It's bad. All right. Next we have some terms, our mathematical terms. We're referring to number. Prevalence. The total. You do need to know the difference between prevalence and incidence. For sure. I know you need to know that. Okay. Prevalence is the total number of existing cases in that population for that outbreak. Total. Incidence is over a certain time period. So think of like X cases per month or something. We've had blah, blah, blah cases this week. That's the incidence. Prevalence is total. All right. Morbidity rate is the same thing as incidence. Mortality rate is deaths. All right, let's go over some epidemic patterns. Epidemic patterns will include point source epidemic. These are coming from a single source and all victims were exposed at the same time. A point source. So a point in time and a single source. Point in time, single source. What would an example of that be? I came in from my trip to France and I came in here and coughed the whole time while I was lecturing and you guys all got COVID from that. That's a point source epidemic. You were all exposed to just that one moment, all at the same time. Okay.
So epidemiologists that were probably really like those. It's a lot easier to figure out or deal with, I guess.
What do you mean?
Well, like if they're all coming from one place, we're trying to figure out where it came from. At least if they all came from one place at the same time.
Yeah.
Once you figured out that
Potentially, right? Potentially, but sometimes if something has gotten so far that you can't trace it back to a specific
right.
point, then that could be an issue. All right. So then we have common source epidemic. This is like what we saw with John Snow's situation. Everybody's going to that one source. It was common to everybody, but it wasn't all at one time, right? It was over weeks people were using this water pump getting sick. So they weren't exposed all at one time, but from that one source. Then we have propagated epidemics. This would be like flu. we maintain the flu in our population for the most part. It might just go up and down, but it's maintained within the human population. Same thing now with COVID, right? We've reached that state with COVID. So that's propagated. We're propagating it within the human population. Like I said, this is a lot of terms, y'all. Our index case is the first patient that had it in an investigation. An endemic means that it is steady in your area. So you're used to seeing it in your area. Like if people started getting colds every once in a while, we'd be like, yeah, that happens. We have that here in the world that we call the world. So you wouldn't be surprised. That's endemic, right? Sporadic disease is just random, occasional, irregular, we would say. So sporadic, that would be like rabies. So you don't see a lot of that. Somebody got that, that'd be very, very sporadic. It's not going to be associated with a true epidemic. Whereas an epidemic is the prevalence, which is that total population number, is going to be increasing beyond what's expected. That's the literal definition. Our prevalence is increasing beyond what's expected. So if you didn't have it in your population at all to begin with, that's beyond what you expected, right? So when we had the introduction of COVID, that was an epidemic, even though, even if only a couple people had gotten infected, still, it's more than what you expected. Now, for sure, we know it's gone beyond that. All right, so epidemic beyond what you're expected at all. If you have occasional cold cases, but then all of a sudden everybody's getting the cold, like everybody left and right, everybody's got the cold, that's beyond what it would be expected. Epidemic, even though it's normally seen there. All right, pandemic, now we're crossing continents. All right, don't really care about this, but it's just talking about the progress of disease. It's all related pretty closely to the progression of disease itself. But talking about susceptible hosts, these are people that can be infected, people who might have subclinical disease that could be carriers and things like that, okay? There's only 3 ways that can happen if you have an epidemic occurring. You could have somebody who has a complete recovery, or they could have a disability from their symptoms that remain, or they could die. That's the options. All right, we can screen to try to detect things early. Screening is different from diagnostic tests. Diagnostic tests are usually more invasive and all that. So anyways, screening, here we're trying to just like upfront say, is there a risk that this person has this thing? Screening includes things like if you were going at home and you thought you had a sore throat and you do a COVID test real quick, that's screening, right? You can sometimes use those as diagnostics depending on the test, but usually if you were to test positive on a home test nowadays, they're still going to want to push for a PCR test just to confirm that it is in fact true, so they can track that appropriately with the CDC and make sure that, you know, keep an eye on it, which is kind of what this whole chapter is about. But pap smears, geez man, everybody losing their dog today. These are screening tests, pap smears are. So they're not there to like be a definitive saying whether you have cancer or not, but to see if you could potentially have cancerous cells. And then they'll go in and do a biopsy or a colposcopy to see if you truly have cancer later on, if this comes back with concerning results. So that's the difference there. Tests can be specific or sensitive, okay? So here's how we can remember these. Sensitivity, I always start with sensitivity. If you're really, really sensitive, so I guess my last example was flashlight, right? If I have a flashlight and I'm holding it, or a big lantern, right? Lantern's hanging up in the woods, we're going camping, you and me. And we're walking away from the lantern, and it gets like less and less and less and less bright, right? Sensitivity, if you were really, really sensitive, would be somebody who's sensitive could see that light from as far away as you could possibly imagine. Like that it was there, okay? So sensitivity is always finding the positives, even if it's just barely positive. Always find all positives, that's the goal. And then specificity means that you only find positives, true positives. So you're eliminating false positives with that one. In sensitivity, you're eliminating false negatives. Okay, so that's the difference with these. That's why I like to start with sensitivity, because then I'm like, okay, now I'm left with the other option. I like to break it down that way. That's just the way my mind works. I don't know. Then we can try to figure out what the cause is of something. I'm not going to go into that too much, but you do want to look at correlation and causation, but don't always lean on correlation. So what I mean is, if you guys came in here and I'm over here standing over Dr. Rhodes and I've got blood all over my hands, he's dead. You guys, that's a correlation to assume maybe she killed him. And then be worried about that. But that's just a correlation, right? Can you prove that that was the cause? No, you'd have to be, well, maybe she was just trying to, give him CPR and he had blood all over him or something like that. You don't know yet. So don't forget, correlation and causation are different things. So we want to do some studies, some randomized control trials to try to determine about cause, correlation of our diseases and what's going on, okay? So in epidemiology, we have, oh God, I can do it. I know I can. I know we're late, but I mean, I'm hoping to kick it out fast. Cross-sectional studies. These are two factors, looking at two factors at one point in time. Any two factors, but some obvious ones would be how you were exposed to the thing and whatever the disease is, having it, let's say, having the disease, whatever it is. So taking a cross-section at a specific point of time and looking at two things. Case control studies. Here we have a group of people, and we're going to split them up as whether they have the condition or not. And then we ask them about exposures and other questions potentially that they had. So can we, by splitting apart this group of people, some have and some don't, can we determine what the cause is by asking the haves and the don't haves? Okay. Whereas taking it further, we have cohort studies. These are looking at only people without the condition, following them over time and seeing if they get sick, what may have led to it, and if they didn't, what the difference is. So that's looking at over time. All right, you want to have surveillance for these things and report diseases that are reportable according to the CDC and the World Health Organization. Cool. You do want to be aware of hospital or healthcare, I should say, associated infections like those associated with catheters, central lines, surgical sites, and ventilators. There's all sorts of programs that your infection control officer can put into place that will often include medical versus surgical asepsis, which are different things. Medical asepsis is talking about washing your hands, using fresh gloves, wearing PPE, things like that. Whereas surgical asepsis is taking it to as sterile as possible. You don't always need to aim for as sterile as possible for everyday life. That's what medical asepsis is talking about, just the kind of normal patient situation, right? Okay, we were talking about infection control. Okay, R naught and case fatality rate. R naught, that's this R sub 0. I call it R naught. No, I won't pretty much ever call it that. This is how many people you're going to infect with that disease that you have during the course of your infection. So if you get COVID, how many people are you likely to infect during the whole time you're sick? That's R naught. So we have an average of that for every disease. So I think for COVID right now, it's around 5. The current strain is around 5. So you get sick with COVID, you're likely to infect about 5 other people.
Were the numbers higher?
They were lower. They've gotten higher. So it's more infectious now, but because of the vaccine, it's not as much of an issue. Yeah. That's of course part of it too. Yeah. So the more, and of course, it's been like that for a few years, but in the beginning it was, I would say, like in the 3s or somewhere. They didn't have good numbers on it because it's so new, but then it went down because of social distancing. So, which works, right? It actually works. And then we have case fatality rate. This is going to be people who die. If you are sick, the number of people who die. So literally the number of people who die out of those who got sick. If that makes sense. Not out of the whole entire population, but out of those who got sick. Then this can all be dependent on where you're living, the circumstances of the outbreak, and the microbe itself. Anyways, we look here. This is case fatality versus communicability. The ones that are the most deadly, like rabies, right? It's up at the top. It's not very communicable. Not surprising, right? So these tend to be relatively inverse, not always. Look at measles. Super communicable. It's one of the most communicable diseases that we know of. But it's not very deadly typically. We want to be sure that you are getting vaccinated because we want to achieve herd immunity. This is whenever we have enough people vaccinated for that disease in the population that we can protect the unvaccinated. So enough people are protected, the unvaccinated can't get the disease or are less likely to get the disease. Now, if you're unvaccinated, it could be by choice or it could be by you cannot get the vaccine for whatever reason, allergic or too sick to have it or whatever it is, or baby, right? So herd immunity says you get the vaccine, you've protected yourself, everybody gets the vaccine, we protected everybody else, including the few that can't get it. However, this depends entirely on that or not. So if you are talking about a very communicable disease like measles, where you're likely to get a ton of people infected if they weren't vaccinated, then you need a much higher number of people vaccinated to protect everybody, which is why with the anti-vax movement, you're seeing an increase with measles because herd immunity isn't protecting them anymore because people who are anti-vaxxers seem to think you're not really going to get it. It's not really going to be that bad. Turns out you were protected by herd immunity and now you're not. So have fun with that. So you guys know, so vaccinate. Here is the process for getting approval of new vaccines. I think I had said this before, maybe I didn't. They didn't rush ahead with the COVID vaccine. That was a big issue. They thought they skipped in the clinical trials just to get it out to us and it was against the law, but they made exceptions and why is that fair and whatever. They did not. They were doing very well in phase 2. So they just jumped into phase 3 without finishing phase 2. So they still finished phase 2 though. They went fine. So they didn't cheat. So that's just how that goes, okay?
So why do some people come out, like I had a patient the other day that she got the vaccine and then all of a sudden she started having heart. Is there a reason that people tend to say, oh, this COVID vaccine gave me?
It's tough, right? So if you are having an inflammatory response to something that is new in your body, potentially you could react to it in a way that could cause you to have inflammatory reactions to your own body as a result. These things are incredibly rare, but it would be things like Guillain-Barré and stuff like that. They exist, but they're incredibly rare. Whenever you had COVID arm, like I had COVID arm, my first shot, and it was my whole arm. Oh my God, it was a whole thing. It was all red and swollen. And that was my body mounting an immune response to the mRNA, right? And what we're making from the mRNA protein. But anyways, as it's attacking that, it's also attacking the tissue nearby. And that's not normal with what you usually see with other vaccines that don't have that. That's a new kind of vaccine. So that was normal and to be expected. People who got outside of that though, it's harder to tell. So that's why they have things like the vaccine adverse events reporting system now, because so many people were reporting adverse effects from their vaccines. Now, if this person really did think it was from the vaccine, they could contact these people and let them know about it, and then they could do a testing to see, follow up and see if this is related to other people having this, or if this is just something that they think is correlated and it isn't, which is probably the more likely situation. I hate to say it, but it probably is. As just to be clear, somebody was talking about this with me the other day about I just want to be sure I did it. Okay, cool. Somebody the other day about how, like, oh yeah, when I get the flu vaccine, every time I get the flu vaccine, I get sick. Nope, you didn't. Nope, that is your body reacting to the flu vaccine the way that it should. That's your body having an immune response. And you should have those things. Are you sick? Well, I mean, you're having the symptoms like you're sick, but you're not actually infected, right? So a lot of people think that these vaccines, because they're having an immune response, can make you sick and that like infected sick. And that's usually not the case. Very unlikely and very rare. Almost none of them actually have live virus in them. Very few of them do. And it's usually a special case. If you are somebody who's allergic to eggs, then you probably got the vaccine from the live attenuated virus, then you could have gotten flu from that. But if you were getting shots for your flu virus, you are not getting the flu. Nope. So anyways, these are parasitic infections that people can have here in the United States of America. I'm not going to test you on them, but there they are if you're interested. Okay. So now we're ready to go to the lab. We did it. I don't have to do it. You got your terms. You got to ask questions. We survived it. I don't know how. I only did one class. I didn't make it through it.